Good morning, good afternoon, or good evening, wherever you are joining us from. My name is Ann Brazo. I'm the CEO and founder of MPN Advocacy and Education International. We are celebrating our 11th year. However, I've been in this space for 21 years. And with us today, I'm so happy because we happen to like him very much, and his patients like him very much, and he does excellent work at MD Anderson in Houston, Texas. And Dr. Bose is with us today. He's going to talk about Polycythemia Vera. And we have quite a few people on this webinar, Dr. Bose. And so if you wouldn't mind just maybe sharing at first some of these and anything that you can share to start off, and then we have a ton of questions for you.
Yeah, sure. Thanks, Anne, again for having me, and thank you to all our viewers for attending this. So, again, I'm not sure to what extent you'd like me, Anne, to go into an overview of PV or that's not
whatever
necessary.
yes, an overview of perhaps, the new drugs and how they're working, or, whatever you'd like to share at this point, and perhaps some of your research that, you'd like to share with our guests.
Sure, absolutely. I'll try to keep this brief, but PV, is the most common of the classic MPNs, and obviously the good news with PV is that survival is relatively good, and it's been published median in the range of 18-19 years, but that is of course very age dependent and stuff like that. But in general, it's an indolent MPN. And people live many years with it, but that also means that there are symptoms that people have to deal with on an ongoing basis, and there is the risk of blood clots. So until about now, or until about maybe a couple of years ago, the treatment of PV really centered around preventing those blood clots, and that was really all we could do, and that may be changing. So again, very simply put, people were or still are actually categorized as having low risk or high risk PV. And low risk is if you're younger than 60 and have never had a blood clot. High risk is if you have any of those features, have had a prior clot, or are 60 or older. And based on that, the treatment typically is or was phlebotomy, therapeutic phlebotomy, which is essentially taking out some blood so that you deplete iron from the bone marrow. So you sort of starve the bone marrow with regards to iron, and it just cannot make as many red blood cells. And that is really what was done for low-risk patients, along with a baby aspirin. And then for high-risk patients, the paradigm has been cytoreductive therapy, so that you don't need those phlebotomies or only minimally need them, and also the aspirin. So this is how we've thought about PV, but a lot is actually changing. So, for example, if we start with low-risk PV, I just said that the paradigm has been not to use cytoreductive therapy in that setting, but that may be changing. For example, ropeg interferon alpha 2b, approved in the United States in 2021 and in 2019, actually in Europe, is a drug that may have the potential to really alter the long-term outcome. So realize that historically, we've only tried to prevent blood clots, but now we may have an opportunity to really impact the underlying disease and its natural course. So PV patients can develop myelofibrosis, and rarely, unfortunately, even AML, acute myeloid leukemia, which is really a devastating diagnosis. But so now we are in I think, a new era where we may be able to treat not just for clots, but actually to make an impact on what really matters. Not to undermine the importance of preventing clots, but obviously, when patients are surveyed, their main goal, I think, from what I understand from my own patients and also the results of surveys, is to prevent long-term disease progression. So those things are now coming in with, for example, ROPEG, interferon alpha 2b that I just alluded to, has a broad approval. It's not a line. It's not specific to a line of therapy or even to low risk versus high risk. It's really anyone with PV in the US. The European language is a little different, but there too it's not based on a certain risk category. So that's one. And then, another important point to make is that if somebody is getting cytoreductive therapy, like I said, the high-risk patients typically are offered cytoreductive therapy of some kind. It could be hydroxyurea, it could be interferon, like ROPEG that we just alluded to, it could be ruxolitinib. So any of these drugs, at least my goal when I practice is, if I'm using those drugs, I don't want the patient to also be needing phlebotomies. And I really emphasize this point because, again, I understand that this may not be a universally agreed upon theme, but the way I look at it is that if I'm giving them a cytoreductive drug, my goal is to absolutely eliminate phlebotomy because I need to keep that hematocrit under 45 at all times. And if I'm not doing that, maybe my drug is not optimal, So along those lines, there is a class of drugs, again, and in keeping with the spirit of what you asked me to talk about, which is newer drugs, there is a group of drugs termed hepcidin mimetics or hepcidin inducers. Now, these drugs either work like hepcidin or they increase our own hepcidin. And by doing that, by having more hepcidin around, what you're really doing is you're sequestering or storing iron away in what is called the reticuloendothelial system, and thus the bone marrow is unable to access it. So you're really depriving the bone marrow of the iron, and so it's sort of starved of iron and cannot make red blood cells. Sort of what phlebotomy also works through, but this is obviously a more sophisticated mechanism, and also it avoids the unpredictability of phlebotomy, where people don't know what their hematocrit is on a daily basis, right? They only know when they check. So when they check, and if it's over 45, they get a phlebotomy. But with these drugs, they do a really good job of really keeping that hematocrit stable where it needs to be without the ups and downs. So this is an important adjunct in my view. Again, these are not approved yet, just to be clear for our listeners. But when they do get approved, I think they could be a nice adjunct to what people are already doing in terms of, say, cytoreductive therapy, because these drugs, the hepcidin class, they lack that disease-modifying ability. They are really very good at one thing, which is to keep the hematocrit under control. So I think they could be really good adjuncts for our cytoreductive therapy. I already talked some about ROPEG and the potential of interferons to really impact that long-term outcome. Finally, ruxolitinib. Ruxolitinib is a JAK inhibitor, been around for 10 years almost for PV now. And this is, again, a really good drug approved in the hydroxyurea resistant or intolerant setting, both in the US and in Europe. And this drug, controls the hematocrit, controls blood counts in general. White blood cell counts, for example, have been linked to thrombosis, so it's important to control them. Shrinks the spleen when it's enlarged. And now we are learning that ruxolitinib also does two other things that people were not sure it did. So one, it reduces the risk of blood clots. That's now been shown in a study called the MAGIC PV study. And then also that, like interferons, it reduces the level of JAK2. And the patients who get that reduction are the ones who have the best event-free survival. So these things came to light from the recent MAGIC PV study. And again, I neglected to mention this when talking about interferons, but interferons have been the classic agent for reducing that JAK2, what we call allele burden or variant allele frequency, essentially the percentage of cells in the bone marrow that carry the mutation. And so, and at least conceptually, you'd think that doing that will correlate with improved outcomes, right? I mean, ultimately, we care about outcomes, not so much about the mutation level. But with both ropeg and now ruxolitinib, we are seeing improved event-free survival. Now, the settings are a bit different. Ruxolitinib has mainly been studied after hydroxyurea. Ropeg is more frontline, although it's a mix. It's been studied in all settings. But we're now in this era where we are probably moving away from only reducing blood clots to really impacting other pretty much everything that ultimately matters, which is, blood clots, progression to myelofibrosis, and transformation to AML. So I think we're starting to have the tools that can do these for us.
Fantastic update, and really, Dr. Bose, excellent.
Thank you.
And to piggyback some of what you were saying, there's no question combination drug therapy is everywhere, and I mean in trials and so on, and also individualizing medicine or treatment plans, because as you know, the MPN community, the community of patients anyway, there's so much heterogeneity that it's sometimes probably, I'm sure you see it every day, that this person does well on this and this person has no symptoms and this person, so would you say combination drugs are definitely going to be the way of the future and are now? Or of course, the goal, I love your goal of one thing doing everything for these patients. That would be fantastic. What are your thoughts on that?
So great question. And I mean, I think with combinations, we are almost there in myelofibrosis,
Yes.
right? But again, myelofibrosis, median survival 7 years. It's a little bit of a different discussion, right? With PV, we may certainly get there, but I don't know that we are in the combination era yet. However, I will again, reiterate what I said about the hepcidin class of drugs. To me, they are best used in combination when they get approved. Because again, they do a fantastic job in one aspect, right? Not so much with white blood cells or long-term disease modification or reducing the JAK2 level, at least not that we know of. But they do a beautiful job with the hematocrit. So I think they could be a good partner for whether it is ropeg or hydrea or Jakafi or ruxolitinib, all of these, which are, our conventional cytoreductive, tools, they could combine well with them.
Okay. So I'm going to go to our questions, and if you have questions, please send them along, and Mallory will get those to me as soon as she gets them, and we'll ask as many as we can. Does brain fog come with PV, or could it be a side effect from my medication?
Yeah, so brain fog is a part of PV and other MPNs. It is captured by, I think to some extent, by the term trouble concentrating, which you will see in the MPN 10 questionnaire, which again, some physicians use, some don't, but it's a well-established questionnaire. Clinical trials, we use it. So that trouble concentrating piece really reflects the brain fog, right? So this is, I think, more from the disease than from the therapy. And unfortunately, we don't have a good pharmacologic solution to this.
And that was the next question. What can that person do to eliminate that or decrease it? And there really isn't anything at this point.
Well, not specifically, but I would say that, again, of course, keep your hematocrit always at goal, because if that is high, it's going to get worse. But probably nothing specific to brain fog.
Okay. We hear and have heard, I've heard for years, about the terrible itching that PV patients experience. And I know of some pretty disastrous outcomes from that. And we still see patients and hear from patients that experience this extraordinary itching, especially after showers and under certain circumstances. There must be something now. I mean, I've heard a lot of different individuals say that it has decreased with Jakafi, that it has decreased with antihistamines, certain things. Can you shed some light on that?
Yeah, I agree that ruxolitinib is probably far and away the best drug for this because itching is a cytokine-mediated symptom. So it would make sense that a JAK inhibitor would do this better than anything else. And that has been my experience. I have one patient, for example, who his itching comes back if you even go from 20 to 15 on the Jakafi. You have to stay at 20 twice a day for that patient. Now, I do want to be clear. It is uncommon, I think, for PV patients to need 20 twice a day. You start at 10 twice a day, and generally the up titration is based on your blood count control. But some patients could need higher doses. Like I said, I do have this one patient who swears by the 20 milligram twice a day of his ruxolitinib, and we've tried going down with not so good results and had to go back up. So I think among our cytoreductive drugs, that's the main one. And you mentioned adjuncts like antihistamines, maybe even SSRIs. There are certain things that have been used, but I find that Jakafi is the way to go.
And how would you compare that to the other JAK inhibitors that have been approved in the last few years?
So fedratinib, pacritinib, and momelotinib have either not been studied in PV or studied with not so great results.
That's true.
Momelotinib, for example, which is a great new addition to the myelofibrosis armamentarium, was studied in PV. It was a trial that's been published, and that was not a very promising outcome. They were not very encouraging results. So I'm not aware of any development plans for these three JAK inhibitors in PV. In fact, fedratinib and pacritinib, I'm not even certain was studied. Fedratinib might have been, but I think bottom line is none of those three have shown any meaningful signal in PV that I'm aware of.
Yeah, I think you're right with that. All right, there's a great deal of praise for the drug Jakafi, yet it seems to be acknowledged that 50% of patients will need to come off the drug within 3 years due to worsening symptoms or even progression to AML. If this is true, is there not some commonality among these failed patients that may suggest which patients may or may not do well on Jakafi? Great question.
Yes, however, I will point out that that statement applies to MF.
Okay.
So very key distinction, and that 50% coming off in 3 years is coming straight out of the MF literature. In PV, they actually do much better. And that probably reflects the indolent nature of PV, right? So I certainly do not think anywhere near that percentage would be coming off at 3 years.
Okay.
But whoever said that is exactly right from an MF standpoint.
Okay.
And also the risk of AML is much higher in MF. It's about 20% of patients with MF by 10 years, will develop AML. And that is partly why the median survival of MF is also quite a bit worse than PV, right? So I think, yes, that, while that does not apply to PV, of course, some PV still transform to AML and directly without an MF phase. It can happen. I've seen PV also transform to MDS. So I think it is hard, of course, to know who those people are. But if you see a bunch of other mutations, right? For example, it's been published that SRSF2 is a bad mutation in PV. those patients have a worse survival, higher rates of leukemic transformation. So if you see things like that, then of course you're more concerned. But today our therapeutic approach is not different based on that sort of information. Now, again, because interferons have had this long story of being disease modifying, perhaps one could argue, use interferon in a higher risk patient, but it's also been published that interferons don't work as well when you have other mutations.
Right.
And they work best when you just have JAK2.
Mm-hmm.
So I think this is a very important question and an unmet need. I don't know that we, while we can identify high risk, like high white count is not a good thing, and similarly the mutations that I spoke of, but the treatments don't differ, at least today, based on those things.
So we talk to the parents of children with PV and ET usually. I know a few with MF, but mostly PV and ET. But for the parents with children with PV, and some of those children were diagnosed at 7, 8. There are a few teenagers now that we are in pretty, constant touch with. But one is really doing poorly that I know of. And some of his issues are racing heart, and some other things that scare him. And he's 15, I think, or 16. I know you are not a pediatric MPN specialist, but what advice do you give to the parents of younger children or younger people that have PV that the drug regimen is based on adults, and there's so many other factors going on. What advice would you give to them?
So, and you did hit the nail on the head. I mean, this is not something I do, but I'll just make some very general comments.
Yes, that's
So
okay.
my go-to person is Nicole Cousin at Cornell.
He sees her, I think. Yeah, I think that's her.
Okay, there you go. You're already seeing the
Yeah.
best. But I'll just make some general points. So we know that the best survival is in these younger folks. And that's been published
Yeah.
from multiple groups, that the AYA, or adolescents and young adults with MPNs, primarily PVNET, rarely MF, they do very, very well. So from a survival standpoint. And recently, I just found this intriguing at the ASH meeting of 2023 in San Diego. There was a study from Europe. Claire Harrison was definitely one of the leaders, and there might have been others. I think Jean-Jacques Kilagian was on it as well. I think the two of them may have led it, where they really showed that interferon makes a real difference in I think the endpoint might have been event-free survival or progression-free survival or something like that. But interferon stood out, sort of vindicating something we've heard of for a long time. But I think Claire and Jean-Jacques were able to show that in their adolescent and pediatric study.
Yeah. I know the study you're talking about. It was fantastic. Okay, does your allele burden level contribute to your risk level for progression?
Yes, it does. So the allele burden, there's a few things we know that it does correlate with, right? So let me go through that. One, higher risk of myelofibrosis, which is exactly what you asked. So progression is more in people with a higher allele burden. And then thrombosis, this used to be a little controversial, but I think the field has now settled on this, that if you have a JAK2 allele burden of 50% or more or higher, then at least for venous thrombosis, that is a risk factor. So progression to MF and venous thrombosis for sure are predicted for by a higher allele burden. Now, what continues to be controversial is, should we keep checking it? Does it help to do that? Does lowering it necessarily mean that outcomes will improve? This unfortunately remains controversial. And most physicians, academic or community, do not check serial, JAK2 levels because we don't know what to do with that information. But I think as more and more interest in disease modification evolves, I think I would look forward to more data on correlation between, bringing that level down and improving overall survival, event-free survival, things like that. Now, Jean-Jacques Kilagian in Paris has shown a few years ago that if you're on interferon and you're down to less than 10% on your JAK2 VAF or allele burden, and you are in complete hematologic response, of course, your counts need to be normal, then you can successfully stop interferon. So that was one study that Jean-Jacques and his colleagues had presented. So I think it is important, and I think it will get more important in the coming years. But right now, we don't encourage, just checking it routinely because we simply don't know what to do based on that.
Well, your first answer was yes. And I would have to say years ago, when I first entered this space, and I remember a conversation with several MPN specialists, there were only several back then, it was just a handful. And they said, oh, the allele burden has nothing to do with it, so the thought process, it has changed. That has definitely changed. And so I'm glad to hear that. And this person asked, what blood tests confirm that you have the JAK2 mutation?
Oh, that's just, I believe it's a PCR, that you can do for JAK2. And most people these days will do NGS, which is a, next generation sequencing. They'll get a whole panel, not just JAK2. And I'm not sure this is the question, but what has been published also is that blood and marrow are equally reliable for JAK2, which is a nice thing. But NGS is what most people would do.
We get this question a lot, and I know that I had a chat with someone at ASH that said, we really need to look more at the symptoms, and look at what might decrease some of the symptoms like this. And it was neuropathy in the hands and feet. And the question is that a symptom of PV or my medication?
Again, we do hear of it, and not too infrequently. It's not one of the classic symptoms, but I think we hear about it often enough that it could be a reflection of PV. Now, the medications, again, I wouldn't expect Jakafi to cause it or interferon to cause it. Hydroxyurea also, I must say, is certainly not common. So certainly not that something that jumps out as being, oh, that's from your hydroxyurea or that's from your ruxolitinib. Not that. And again, it is one of those where the relationship with PV is not as solid. But, again, going back to that questionnaire I was talking about, most of us use the abbreviated 10-point version of that called MPN 10. But if you go back to the original one that Ruben Mesa and Robin Sherber had first published, they have more items, and numbness, tingling, those things are in there. Now, is that from hyperviscosity or is that neuropathy? That's a bit hard to say, but I'm inclined to think it could be a PV symptom. And sorry, Anne, I missed your comment there.
No, I just said in bone pain, because I've been hearing that for years, and the neuropathy, I've been hearing that for years. Eye issues, issues with the eyes. My neighbor has PV, and she came to my house one day and said, my eyes are just, something's wrong. And I said, go to your hematologist. I said, first see him and then, see what he says, because I knew from my experience, my, uneducated experience, that I had heard, so many other people talk about eye issues as well with PV. So,
right. So bone pain for sure, as you said, and that's a solid, well-established MPN symptom. Regarding the eyes, obviously, if your hematocrit is high, you're going to get blurry vision.
Yeah.
And then also, even if it's not high, Let's say if your platelets are very high, you can get microvascular disturbances. These days, we recommend twice a day baby aspirin in a
Yeah.
lot of patients, or rather than the old once a day. So, not everyone, but those who have problems.
Okay.
So we call these microcirculatory disturbances, and the eyes are often affected.
Okay. And then I know I've heard this before about the hematocrit, and it could be different for men and women. Is it women under 45 or under 42, the hematocrit number?
Yeah, so we use 45. There is the 42, in my view, is not an evidence-based recommendation. It's been around a long time, though. So in my practice, in our practice at MD Anderson, we use 45 for everybody. Now, there could be the occasional patient who already knows that he or she gets symptomatic over 42. Well,
Okay.
if that's the case, of course, you know, but I will also acknowledge that this is it's an issue on which opinion is divided. I do know of some experts who do use 42 for women and 45 for men, but we do not.
Okay. And would can PV make you more prone to arterial plaque disease in your arteries?
Yes, yes. So it's not just venous. Venous clots occur more than arterial clots, but you definitely see arterial clots. Now, is that because there is more plaque versus there is already a plaque and PV, superimposed on top of that causes a clot on the plaque? That I cannot answer, but certainly arterial events are seen. Absolutely.
Can patients manage the fatigue and weight gain from PV? I mean, we know fatigue is the number one, or used to be the number one issue, and
Oh
still
yeah.
can be, definitely.
Mm-hmm. So the weight gain is from Jakafi.
Yeah.
The weight gain is probably not from PV. So that is a classic side effect of ruxolitinib, not an issue that I'm aware of with interferon or hydroxyurea. Some people it can be sometimes it's not very common, but in some patients, I have maybe 2 or 3 patients who've had a real issue with the weight gain. It does tend to level off, but that can be an issue with ruxolitinib. I imagine the person asking the question is on that. Now, the fatigue is a huge deal. I mean, as you said, and I mean, it's the most common symptom across MPNs. And again, it's not a symptom that is well addressed by any pharmacologic therapy. The occasional patients will go on something like a stimulant, right? If it is that bad, they'll maybe go on modafinil or some sort of stimulant, methylphenidate or something like that. We actually have a fatigue clinic at MD Anderson where because it's so pervasive across cancers, so our supportive care group has a fatigue clinic. But our conventional therapies for MPN, I don't think address fatigue well.
Doesn't. I know. I mean, and that's again in that list of all the symptoms that in our minds has grown exponentially over the years, because I find patients are more vocal about it. They're asking more questions about, well, I never had this issue and now I have this issue. And we have a patient advisory council, and we had a meeting recently with 10 of them, and the issues they presented were very real and very different from those standard lists. And one thing that came up was when they had colds or flus or any kind of illness, it took much longer for them to recover, even the
Okay.
healthier ones, that they seemed to still have nagging, and it wasn't COVID, it was other stuff.
Right.
So I thought that was interesting, and among other things, but how that list of symptoms that some of them are there, but they're not as pronounced as fatigue.
No,
But
and actually something you said, it's very intriguing. I'm wondering if the people who reported this were on ruxolitinib, because ruxolitinib impairs, certain aspects of our immunity. That is well established. In fact, this is why it works in a condition called GVHD,
yes,
after transplant, as you will know.
Yeah.
So it is a fairly potent immunosuppressive drug. And I'm just wondering, curious,
Oh,
if those who are reporting this difficulty with clearing these infections are on
that's a
Rux.
very great point, Dr. Bose. That's a really excellent point.
It's just a thought. Yeah, I
Yeah,
mean,
it's a
it's
thought,
generally
but
a
it's
very
something
well
to think
tolerated
about.
drug.
It's something to really look at and think about. Do you know anything about rapamycin use for PV? It's rapamycin. I've never heard of it.
Yeah, so rapamycin in PV,
Rapamycin. See, I know.
no problem. Rapamycin in PV, no, I have not heard, I've never heard about that.
Yeah.
But rapamycin, to my knowledge, is a very potent immunosuppressant. It is something used after transplant to
Mm-hmm.
prevent rejection.
Mm-hmm.
So it's interesting that we are talking about it right after I made that comment about ruxolitinib. But no, I have not never come across rapamycin as a treatment for PV.
So two really interesting questions. Is there any testing that can be done to determine how long one has had PV? And I like this question because we meet so many patients that say, but I think I've had it longer. I was diagnosed 5 months ago or a year ago, but I think I've had it longer. And we always say, well, the one way you could do that is look back at your medical records and your blood work and see if anyone, and I do know people that their blood work was ignored, that their platelets were very high and other issues were going on, and there was no conversation about it.
No, I can understand why this is an important question for patients, right? Because they're going to read or hear about the median survival.
Yeah.
And the first thing they're going to think of is, how long have I had it? So this is not easy to, I mean, not at all easy to put a finger on. As you said, and looking back at the blood counts, maybe the best one can do. Now, but interestingly, if you shift gears a bit to the research side, the JAK2 mutation has been found to arise even in infancy or before that. It can even arise in utero before one is born. So, but it takes a long time for the mutation which is present to actually cause the disease, right? But this is all, it's fascinating, but this is all in the realm of research. Totally, there's no way one can tell a given patient when did yours start, other than looking at the old blood counts, like you said.
Mm-hmm. Mm-hmm. The next question is, I don't have a gene mutation and was still diagnosed with PV. Is this common? And I remember meeting many patients, like a handful of patients that have said, I don't have the JAK2 gene mutation.
Yeah. So this is very uncommon, very uncommon. It's about 1% that will not have a JAK2 mutation. I would be suspicious of the diagnosis. Again, I'm sure, those in this situation have gone to several doctors, but it should always make you very suspicious of the PV diagnosis if you don't have a JAK2 mutation, because it's only 1%.
What are your thoughts on combination therapy with pegasys and rusfertide?
Yeah, I actually think this is an interesting thought because, what we've learned with interferons is that they don't work very fast. And that can be a problem for some people. So some people have very proliferative disease and they're needing phlebotomies all the time. They may be on interferon, but it may not be preventing that. They may still be needing phlebotomies. And we actually saw this in the ROPEG trial. There was a trial done called the PROUD PV study, where ROPEG was compared to hydroxyurea. And for the first year, hydroxyurea was better because
Mm-hmm.
interferons just take longer to really get into the act. So, and then from the second through the 6th years, ROPEG was better. But it showed you that in the first year, interferons may well lag behind. So it's often occurred to me that a drug like rusfertide, which does a fantastic job at controlling the hematocrit, could be a great adjunct. And I was alluding to this before. Like, let's say you use Pegasys or ROPEG, whatever, you use an interferon for disease modification for your long-term goals. and you combine that with rusfertide for the more immediate goal of controlling the hematocrit. So I think that is a good question, a good thing to explore.
Should PV patients take iron supplements or try the carnivore diet if they have no iron storage in biopsy results? Great
Yeah,
questions.
absolutely, absolutely. Only very carefully. So the general answer is no, do
Right,
not take iron
right.
supplements, because again, you're adding fuel to the fire. You're going to make more red blood cells. But we all recognize that there can be situations where both your PV and the phlebotomies that you're getting make you severely iron deficient. And in conjunction with your doctor, it may be safe to take a low dose of a supplement, but absolutely not as a general answer.
Can PV contribute to kidney stones?
Perhaps through uric acid, because any MPN will give you high uric acid. Because as the cells die and new ones are formed, what we call turnover of cells, uric acid is released. And uric acid can lead to kidney stones. But this is really more of a theoretical answer. I don't know if PV patients have an excess incidence of uric acid stones, but that is a plausible link that I can see.
Can taking blood thinners and steroids help slow down PV?
Not that I would think, because it is a clonal process. It is driven by the JAK2 mutation. And so unless you do something to curb that, which is interferon, maybe ruxolitinib, I don't see that how steroids or blood thinners would slow down the progression. I mean, they may help you with blood clots, of course, but not the actual disease.
And a question, in patients with the high JAK2 VAF and secondary or more mutations, how do you maintain the patient in the chronic stage and prevent progression?
Right. So this is what we were talking about
Yeah,
earlier, that,
yeah.
high JAK2 is a concern, high white count, especially an increasing white count. John Mascarenhas and others have published on this, that an increasing white count is a bad thing from a progression standpoint. So what is unknown is whether a specific intervention that can, say, control the white count really changes the outcome. So that remains unknown. But those are certainly red flags. And I think the only two drugs for which there is some data now about their being able to improve event-free survival, and I know that's a difficult term, but event-free survival basically means survival without a clot, without myelofibrosis, and without AML. So that's what those are called events. So event-free survival improvement has only been shown for ropeg interferon alpha 2b or Besremi and Jakafi or ruxolitinib.
So this person has PV, and they also have bladder cancer, and they're being treated with BCG for the bladder cancer, which means they cannot take other drugs for the PV, and they are currently just on aspirin. Anything else they could do to treat the PV?
So one, I'm surprised to hear this, because I thought BCG was given intravesically, which means into the bladder, and not as a systemic treatment. So I'm surprised to hear that they cannot take other drugs. But I would encourage them to at least explore, could they take interferon? Like, maybe they cannot take hydroxyurea because it lowers blood counts.
Right.
And it's chemo, but maybe they can take interferon, or maybe they can take a JAK inhibitor. I would look more into this. I'm a bit surprised to hear that.
A couple more questions here. We have about 15 minutes. Is PV considered a blood cancer or a disease, and can a cure ever be found? And when I first started, these were called disorders.
Yeah.
And then the World Health Organization designated MPNs as blood cancers
Right.
and neoplasms.
Right.
And but so they are a blood cancer, correct?
Yes, they are a blood cancer. They are driven by a gene mutation. They are what we call clonal disorders, and so yes, they are they are cancers. And sometimes that can actually help because, patients often are able to avail of certain programs because of the recognition that these are cancers, in terms of certain benefits and
Sure.
things like that. Uh, can a cure? Well, I mean, that is what the field is really striving towards. I mean, again, we talked a lot about interferons and JAK inhibitors today. There's also drugs like HDAC inhibitors, LSD1 inhibitors, which are being studied. So the whole goal is to get at the underlying disease biology rather than just reduce blood clots, which hydroxyurea, has done for many decades.
And as far as a stem cell transplant, so far they can only be done in MF patients, and they have to meet a certain criteria, correct?
Yes, so sadly, transplant is not really an option for PV. And the simple reason being that transplant is a very risky tool. So you have a straight out of the gate 10% chance of dying from a transplant, even in very good hands. So the issue with PV is that if you're going to live a median of, let's say, 19 years, based on one of the publications, then it simply is not worth the risk. So I was actually once asked by a very young patient that why can I not get a transplant to get rid of this. But our transplanters, that was their argument that, we could end up killing him by doing this. So that is the issue there. Even with MF, it is only typically recommended for those who have a less than 5-year life expectancy. That's the rule of thumb. So it's just not worth the trade-off when the disease is indolent.
Is there any correlation, and I think you kind of answered this a little bit, between PV and benign heart palpitations?
Not directly that I can think of. I mean, anagrelide is a notorious drug for causing palpitations, but not commonly used in PV. Sometimes maybe to bring the platelets down, but not commonly used. No, I mean, I'm not sure of a direct link between those two things.
And, many, for some of the patients that are 60 and above, pretty soon, many of them have to start taking other medications.
Yeah.
And so there's fear of, is my cholesterol medicine or my high anxiety whatever it is, does that conflict? I mean, I'm certain the physician looks at that and says, let's see what else you're taking and, if there are any issues, but does that interfere with the progression or inflammation? And we haven't talked about inflammation, but that is our next question.
No, so not only does it not interfere, it is actually very important
Yeah.
that you manage your blood pressure, manage your diabetes, manage your cholesterol, because you're talking about a lifelong disease here, which increases your chance of blood clots, right? So stroke, heart attack, that's the first thing to prevent. I think the discussion about not letting it turn into MF or AML is the second point. I think the first issue, it always has been, is to prevent blood clots. So absolutely manage your cardiovascular risk factors as well as you can, which are weight, blood pressure, sugar, and cholesterol. So those medicines are very important to take.
Do you see a lot of patients with that are using hydroxyurea with mouth sores?
No, not a lot of patients. I've
Okay.
seen it occasionally. Maybe maybe a handful of patients, but certainly not a lot. However, there can be other issues with hydroxyurea. So mouth sores are one of them. Something I run into more is at the dose that you need, right, to keep their hematocrit under 45, they're getting leukopenic, or neutropenic. Their neutrophils are going really low, below 1, or their platelets are going below 100. Now, that is called intolerance, just like mouth sores are. These are different forms of intolerance. So I do see that quite a bit more. And those are reasons to switch to ruxolitinib.
We talked about the itching and the pruritus. What causes that? That's what this patient is asking.
Yeah, we understand that in MPNs as a whole, you have elevated levels of cytokines. There are numerous cytokines, interleukin 6, interleukin 8, TNF alpha. There's a massive, there's a plethora of cytokines that go up. And it's been shown actually that with JAK inhibitors particularly, they go down. And then there are, of course, many new drugs, particularly in myelofibrosis, that are also showing the same kind of thing. So itching is believed to be a cytokine-mediated symptom. Somehow these chemicals cause it.
And this question, of course, I'm sure you hear this all the time, and that is, what is my life expectancy with PV?
Yeah, so and one has to be careful, right? Because you could read the wrong thing and really be, led down the wrong path with
Right.
this. So the median survival in two large studies was in the range of 18 to 19 years. Now, there's been others that have said 14 years, but what is, these are not very helpful because they are just for all comers, large populations, may not apply to you, likely doesn't, I think. But there's been efforts to streamline that. There are prognostic models. Look up something called the MIPS PV,
Yeah.
MIPSS-PV,
Yes.
that allows you to personalize this a bit more. Like, what's your age? What's your white count? Have you had a clot before? Do you have this SRSF2 mutation? So stuff like that, you input those and you get a more refined answer.
Yeah, and I can tell you from my experience, 21 years, I still talk to people that have had PV forever. And
Yeah,
and
yeah,
they've had it additionally, they had it maybe 5 or 10 years when I met them, and
right,
it's 21 years later, and
right,
they're still living life and enjoying life and
absolutely,
have a productive life. So
right.
yes, I would recommend looking at that as
And
well.
younger patients have a better outcome
Yeah.
because that age thing I gave you initially, those are mostly 60 plus patients because that's
Mm-hmm.
who more often gets PV. But
Right.
younger patients have a very different outcome.
Yes. So this question gets asked a lot. Are bone marrow biopsies necessary? And when do you advise a PV patient to have one done?
Well, I think that they are necessary for the diagnosis. Often they are left out, and the diagnosis is made by blood counts and EPO levels and JAK2 mutation, which can work in a lot of people. But maybe I'm being a bit of a purist, but the bone marrow, we always get it because of two things. One, if it already shows some fibrosis at the outset, that just means a higher risk of post-PV myelofibrosis down the road. Now, you might argue that why do I need to know that? I mean, that's a fair point. And then the other thing is that PV can be confused with JAK2 mutated ET.
Mm-hmm.
So, in fact, Jerry Spivak would always say this, and Dr. Silver as well. That if you don't do that bone marrow, there is a good deal of conflation, as they call it, between PV, real PV, and JAK2 mutated ET, because the JAK2 is not going to help you. It can be mutated in both conditions. And sometimes people will use the VAF because it's higher in PV, but that's very inexact. So I think the bone marrow should be done at diagnosis, and then going forward, whenever there is a cause for concern, not otherwise. If
Mm-hmm.
there's something unusual about the blood counts, hemoglobin is going down, or there are more blasts appearing in the blood, spleen is enlarging, those are things that should worry you about. Maybe it's progressing towards MF. And
Mm-hmm.
so then one should do it.
Mm-hmm. I mean, yes, absolutely. And I got a call one time from a person who said, I'm getting my fourth bone marrow biopsy in 6 months. I said, I'm not a physician, but I would question that, and I don't know why. I mean, unless it was just so there was so much uncertainty, I guess.
Yeah, that could be it. It could be maybe it was very difficult to diagnose. Maybe some of them were bad specimens. But one thing I'll throw in is we see a lot of patients who do not have PV, but come for a suspicion or concern for PV. Now, these patients sometimes may end up with multiple. They may have gone to several specialists or first started with their local physician, then gone to another center, and they may have had to have repeated marrows. But remember, there is secondary polycythemia, which is from smoking or sleep apnea or testosterone or some real zebras. There's some very rare inherited conditions. Those are not PV. But those can sort of present like it. And maybe that's what they're alluding to.
Yeah. Well, we are quickly out of time. We have a few more minutes. Any other wisdom you would like to impart? What's coming in the future? What do you see happening in PV specifically? You kind of shared that with us at the onset, but anything else you can leave us with?
Well, no, I think it's been a fantastic discussion. I've loved it. So we already talked about, the hepcidin class of drugs. We talked about interferon, the new emerging information about both ruxolitinib and interferons, actually making a difference to event-free survival and all that. Now, new drugs coming down the pike would be the givinostat, which is an HDAC inhibitor, and bomedemstat maybe, which is an LSD1 inhibitor. But these are early, and it's hard to say right now whether they'll make an impact on the PV field. I think it's a little too premature for those. But I do see perhaps rusfertide that was brought up during the discussion. I expect that to have a positive phase 3 result and get approved. Again, nothing is known right now about the phase 3 in the public domain. They just finished accruing patients to it. So we'll see, but that could be a helpful, adjunct, like I was saying. But I think more and more, I think the field will depart from hydroxyurea towards these more disease-modifying drugs.
Yeah, thankfully.
Like ropeg and rux, etc.
I think that's great. So I can't thank you enough. I know how busy you are and how crazy your schedule is, and I so appreciate you being with us today. It's always a pleasure to see you, and I hope to see you again soon. Tomorrow we'll be talking with Dr. Gabrielle Hobbs, who is going to talk to us about essential thrombocythemia. And then later in April, we will be in Grand Rapids, Michigan for a live program. And you can find that information on our website. But thank you all for joining us today. And a special thanks to these patients and caregivers on with us today. And Dr. Bose, again, we so appreciate your time.
You're welcome, Anne. Thank you as always for having me.
Okay. Bye now.
Bye-bye.